The discussion that comes up frequently is between certain models, socialized medicine versus what we might call free enterprise. Now, the possibilities when we talk about socialized medicine, there are really three models of socialized of medicine in that regard. There is a completely socialized medicine, such as is found in certain countries such as Sweden, Canada, and England. And when I say complete, I don't mean that the entire population is forced to participate in it, because there are some exemptions. However, it is complete in the sense that the payment derives from taxes. Citizens pay taxes, the taxes that are collected by the government, and the government then will turn around and pay healthcare providers. And this is the way it works again in Sweden and England and Canada. The opposite of that would be a free market system where patients pay for their own health care, which is what we had in the United States at least until the mid-60s. Patients initially paid their health care totally out of their own pockets, unless they were able to get donations from charitable organizations such as churches. The result of that was that the price of health care was kept at a relatively low level. The hospitalization, however, was covered often by third-party carriers, meaning insurance companies. The largest one at the time was Blue Cross Blue Shield, which would pay for inpatient services but not for outpatient services. And most people had this kind of coverage. For those who didn't, hospital stays were sometimes affordable or fairly affordable for people even of middle income. Medicare essentially represents a type of socialized medicine, because taxes, and even though we don't call it the income tax, it's a tax we have to pay, this is collected and then paid out by the government to healthcare providers. So to the extent that we have Medicare or Medicaid penetration, we do have socialized medicine. That is why I'm saying that in America right now we have a mixed system. Quality of care, we have to consider price of care, and we have to consider access to care. And those are big issues when a government decides on what kind of system would best serve its subjects. The thinking behind socialized medicine was to increase access, to make it available to people who had even very, very little money. The problems that began to arise then were, as I mentioned, brought about by abuse from both sides. Therefore, there was a tremendous increase in healthcare prices in the countries that were using socialized medicine on a wide scale, like Sweden and England and Canada. And if you reach a point then where your demand exceeds your ability to pay for it, what do? You have two choices. You lower the reimbursements, is what they call it. They're not reimbursements, they're payments to doctors and healthcare givers. That's one method. The other method, the other approach you can take is to limit the use of facilities, limit the amount of care that can be given. Canada in particular, but also, or certain provinces in Canada, I should say, Sweden have opted for that route. This practice of limiting care to reduce costs by limiting the number of procedures that can be performed at various hospitals also takes place in some of the provinces in Canada, and patients are often put on waiting lists. For that reason, many patients will leave Canada and come to the United States, where they can still get procedures done very quickly if they're able to pay for it. Now, there's one more model that I probably should mention, and this was a model that the Germans were using. They were using rather successfully, at least prior to the reunification of Germany, when we were there in the 70s and on into the early 80s. The system that they were using was one where it was not truly socialized medicine, because the government didn't actually collect taxes and use tax money to pay for health care. What they did was to recognize certain insurance companies and authorize them to provide services to their citizens, and then those insurance companies that fell within certain guidelines were put into a pool, and citizens could select between maybe 2 or 3 possibilities, but they were required by law to belong to one of them if their income fell below a certain level, so that only people with a rather high income could opt out of that. Now, the ones that were in these things, one of them was called the AOK, Allgemeine Ortskrankenkasse. It was the largest, and that means the General Local Health Fund. And the interesting feature there was that the people who belonged to that would pay premiums not according to age or previous health problems or so on. It wasn't determined that way. That's the way the insurance companies in America work. They determine this according to age and risk per person. But in Germany, the premiums were determined by income and the person's ability to pay. So that as a doctor at a clinic there, we were paying a few $100s a month, which was the highest rate, whereas other people who were making little or no money might only pay $5 a month. But everybody paid something into it then according to their abilities. And this worked fairly well. Initially, it worked fairly well because the Germans had a work ethic and were not predisposed to abusing the system. Gradually, however, they did begin to abuse the system, and we often had patients who wanted services they didn't really need. Now, problems that we're facing in America are not just the question of pricing or who pays for it, but the cost of health care is affected by another fact here in America. And another ingredient in this equation is that of lawsuits. American doctors are forced to practice what is called defensive medicine. We are forced to run an awful lot of tests frequently, not necessarily because it's standard of care, but in order to avoid lawsuits, we're required to have more documentation than I've seen in any other country. A colleague of mine in Canada, he sees 100 patients a day, and by the way, that's another feature with the private practices we've traditionally had in America. Doctors have been seeing maybe 30 to 40 patients a day. Family practitioners up in Canada are seeing 100 patients a day. Well, how can you do that and provide the kind of documentation that we're forced to have right now in America even to get paid? And the answer is you can't. And as my colleague in Canada pointed out, he barely makes a couple of notes, just the way we used to here. But it's enough to let him know what's going on, because he's not writing the notes for an insurance company or for a lawyer. He's writing the notes for himself. He's in Kurdistan, which I visited to look at their healthcare delivery a few years ago. And they are trying a kind of a mixed system. There is some private pay, and then the government pays for a fair number of people. And in order to keep costs down, instead of limiting access or purposely limiting access, the Kurdish government has opted to cap the amount that doctors are allowed to charge. Over there, a doctor is allowed to charge between $8 and $10 per visit. The result is that the doctors don't make much money. The result of that is they cannot buy equipment.
So what do you think would be the best option for the United States in ways of future changes?
There should be, first of all, the easiest thing would be tort reform. Reducing the amount that doctors have to pay in malpractice. That was done in Texas. In fact, George Bush the younger did that when he was governor, and they capped it so that I think it's a $50,000 maximum, whereas in Ohio we still have lawsuits in the millions of dollars. And so the malpractice premiums are much lower in Texas, and it's cheaper for doctors to practice medicine. One of the other things that has, as I mentioned already, one of the things that's greatly increased the overhead costs for doctors is dealing with third-party payers. When I went into practice prior to that, I got along fine with just one receptionist. I had very low overhead. Now, when I opened an office more recently, I had to have several people because it took 2 people just to file insurance claims. Previously, a patient would walk in. If we charged them $35, they wrote out a check, they walked out. We didn't have anything else to do. I didn't need people who had a specialized education in filing Medicare claims in order to be able to collect some money. And then one of the things the doctors fear, we've been threatened with this 27.4% decrease in Medicare payments, which the Congress recently put off for another year. But if that kicks in, we believe that doctors, there will be a significant number of doctors.
Dr. Wilson has shared with us many interesting facts on our health system, other healthcare systems, and his opinions on what's good and what's not good. Now it's your turn to do the research. As Americans, we can change the future for our children. Family is very important.